Hi, my name is Patrick and I work in Cairns in Far North Queensland. In this video, I will discuss and identify the components of the bag valve mask, identify common airway adjuncts and demonstrate their use, demonstrate the triple airway maneuver and 1 and 2 person bag valve mask ventilation, and finally, discuss some common difficulties in performing bag valve mask ventilation and strategies as to how to overcome these. QAS uses the Mayo brand of single-use only bag valve masks. These come in 3 sizes: adult, pediatric and neonatal. The manufacturer includes a weight recommendation as to which size to use, with neonatal below 6.5 kilos, child between 6.5 and 23 kilos, and adult above 23 kilos. The average age of a person who weighs 23 kilos is between 5 and 6 years. It's a fairly young adult. Volumes to ventilate a patient are based on their weight, 6 to 8 mils per kilo of body weight. Obviously, there's no way to measure this out, so knowledge of the total volume of the bag is important for one to estimate how much to squeeze the bag. For example, an average size adult will require 500 to 600 mils of volume, so roughly 1/3 the total volume of the bag. As a single use only, the Mayo bag valve masks are essentially disposable, and as such are made cheaply and are prone to a number of failures. As part of your checks at the start of a shift, it is crucial that the bag valve mask is removed from its packaging and inspected. One of the most common sites of failure is the air cushion on the face mask itself. Check that there is sufficient air within the cushion and that it's holding its shape without leaking under pressure. The volume within the cushion may be adjusted using a 20 or 50 ml syringe. Make sure one is close to hand in the oxygen kit. The filter is used to protect the non-disposable elements of your equipment from biological contamination. When using a disposable bag valve mask with capnography, this serves to protect your LifePak 12 from fluid from the patient's airway being sucked up into the port. This will lead to inaccurate readings and waveforms. The filter and capnography connection are not included in the Mayo bag valve mask. To save time on scene, remove the bag valve mask from its packaging and connect up the filter and capnography tube prior to the start of shift. The expiratory flow diverter cap allows for the air expelled from the patient to be diverted outside of the device rather than mixed in with the oxygen within the bag. This increases the concentration of oxygen delivered to the patient. The pressure relief plug prevents operator error causing barotrauma by squeezing the bag too forcefully. On the adult size, this is 60 centimeters of water plus or minus 10 centimeters. Ensure that the plug is unplugged. The squeeze bag is another common site of failure. If it's been jammed into the oxygen kit and left deformed for some time, it may lose the ability to spring back into its original shape. This renders it unoperational. Ensure the oxygen tubing is connected with enough flow to ensure that the bag remains inflated. If not, atmospheric air will be drawn in through the valve, delivering lower oxygen concentrations to the patient. The oropharyngeal airway is indicated for use in patients with actual or potential airway obstruction secondary to displacement of the tongue and without a gag reflex. It lifts the tongue off the posterior pharyngeal wall to prevent airway obstructions. Also, it can be used as a bite block. It assists with oropharyngeal suctioning and promotes moulding of the face to the mask during ventilation. There are, however, some complications. It may precipitate vomiting and aspirations in patients with a gag reflex. Size from teeth to the angle of the mandible. Insert backwards and rotate 180 degrees as it's inserted over the tongue, being careful not to cause soft tissue injury to the tongue, palate or pharynx. In children, insert without rotation. The nasopharyngeal airway provides an airway in patients that have an intact gag reflex or trismus, preventing the use of an OP airway. Contraindications include basal skull fracture and complications being epistaxis and aspiration. Lubricate prior to use. Care taken not to obstruct the lumen with lubricant. Size from nostril to meatus of ear. Advance along the septum horizontally and rotated 90 degrees to lie in the nasopharynx. Proper positioning is a crucial element of successful bag valve mask ventilation. Ideal ventilation positioning is obtained by aligning the patient's external auditory meatus with the sternal notch. This may not always be possible in the pre-hospital environment and is also contraindicated in patients with suspected cervical spine injuries. The classic teaching for ventilation positioning involves the triple airway maneuver, combining head tilt, where 2 hands are used to tilt the head in order to open the airway, jaw thrust using the fingers under the angle of the mandible, which moves the tongue anteriorly with the jaw and mouth opening using both thumbs. In patients with a potential cervical spine injury, only perform the jaw thrust and mouth open. This is typically performed in combination with one or more airway adjuncts. Bag valve mask ventilation is indicated in patients in acute respiratory distress, respiratory insufficiency, or respiratory arrest. Single operator bag valve mask ventilation is taught by the QAS using the CE grip. Use the non-dominant hands. Create a C shape with the thumb and index finger over the top of the mask and apply gentle downward pressure. Hook the remaining fingers around the mandible and lift it upward toward the mask, creating the E. Provide a volume of 6 to 8 mL per kilo per breath. Ventilate at a rate of 10 to 12 breaths per minute. That's one breath every 5 to 6 seconds. Give each breath over 1 to 2 seconds. If the patient has intrinsic respiratory drive, assist the patient's breath. In a patient with tachypnea, assist every few breaths. And ventilate at low pressure and low volume to decrease gastric inflation, vomiting, and aspiration. Assess the adequacy of ventilation. Observe for chest rise, improving colour, capnography waveform, and oxygen saturation. Monitor for air leaks, and be watchful of increasing gastric distension. The single-handed bag valve mask technique is taught to paramedics because they may have to perform this life-saving procedure alone. For example, when working as a single officer or in cardiac arrest to maximize crew resources. A two-handed method is superior, and there are several methods to do this. Okay, firstly, the double C technique using the index finger and thumbs of both hands. Or alternatively, the two thumbs down technique, using the thumbs to hold the mask on the patient's face while lifting the mandible with the fingers. Maintaining the seal requires skill and practice. Squeezing the bag is simple and easily coached. You could consider getting a bystander to do it. When encountering problems with ventilation, one should review the key steps of bag valve mask ventilation: the equipment, position, seal, and oxygenation and ventilation. Review your equipment. Is your oxygen source on? Is the bag functioning? Do you have the appropriate airway adjunct? Evaluate patient positioning. Is the ear to sternal notch position attained? Consider redoing the triple airway maneuver. Evaluate your seal. Do you need to change your technique to a 1 or 2 person hold? Does your mask fit properly, or is there an air leak? Aspiration of gastric contents during bag valve mask ventilation is a potential hazard. Gastric inflation can be minimized by using lower inspiratory pressures, which is done by delivering breath slowly and providing smaller tidal volumes. There are also some additional techniques that may assist in ventilation of typically difficult patients. It is hard to maintain a seal on a bearded patient. One thing you can do is the gel method. Applying lubricating gel to the portion of the beard that will be in contact with the face mask and to the cuff of the mask is often sufficient to achieve an adequate seal for the bag valve mask. The occlusive dressing method uses a dressing with a hole cut in it to facilitate a seal. And finally, the pediatric face mask method. The goal here is to create a mask seal just around the nose and occlude the mouth with basic airway maneuvers. This method will not work with an oral airway in situ and will allow air to escape through the mouth when you start ventilating. A nasopharyngeal airway would be best to use in this case. Ventilating the obese patient can also be difficult. There may be difficulty fitting the mask. Chest wall weight and reduced compliance may require higher pressure to overcome, and redundant supraglottic tissue and increased upper airway resistance. Where appropriate, some of these can be overcome by placing the patient in a ramped position. Edentaless patients, or patients who have lost teeth, where possible, leave in the dentures if they are not at risk of causing obstruction. If this is not possible, use a two-handed method and lower lip placement as shown. Okay, that's the end of the presentation. Thank you very much for watching. I hope you found it useful.